Okay, welcome everybody to tonight's talk. What I'd like to do tonight is to review for you how the normal kidney functions, to talk to you about some of the diseases that affect the kidney, and to go over the tests that you can do to check your kidney function. And at the end of the talk, I'd be glad to take any questions from those that have any. So to start, the kidneys are located in your abdominal area in the back, in the upper part of your abdomen, and each kidney weighs about 1/3 of a pound. We have two kidneys. You can see them here. We can get along with one kidney. Why we have two, no one can really answer. It turns out that if you remove one kidney, the other kidney over the next year actually gets bigger and takes on more of the function, so that by the end of a year approximately, you don't have 50% of kidney function as you might expect because you only have one. You actually gain back another 20 or 30%, such that your total kidney function isn't quite normal, but it's very close to normal because of this compensation of the remaining kidney. And that occurs in anyone who donates a kidney, by the way. Your remaining kidney function doesn't stay at 50%, it actually increases over time. Now this graph shows the function of age shown here on the bottom here versus kidney function. And there is a red and a blue line because the blue line represents males and the red line represents women. And what you see here is at the age of 50, you have on average about 100% kidney function. The dotted lines are the sort of the extremes, the limits. So there is a range. But just taking the middle two lines, you can see here that at age 50 with 100% kidney function, these are normal people. There's actually a decline of kidney function with age, a normal decline. This is not a disease process. This occurs normally in all people. You can see that once you reach your 80s, you've actually lost about 20 to 25% of the kidney function you had when you were in your 50s. This is a normal decline, and the decrement in kidney function in your 80s and 90s is not called a disease, although some doctors, many doctors actually aren't aware of this, and they misdiagnose patients who have this normal decline with what's called CKD or chronic kidney disease, and that's really incorrect. This is normality, and the new normal has to be reset to a lower level. But again, this is something that most doctors aren't aware of. They assume that your kidney function in the absence of a disease stays at 100%, but that's not the case. Now, shown here pictorially are the stages of decrease in kidney function with different diseases. And there are many different diseases that I will review that affect the kidney. So on top here is kidney function that's over 90. And that would be close to normality. But as the function decreases, we get these different categories of 60 to 89, 30 to 59, 15 to 29, and less than 15. Each of these is called a different CKD stage. So if it's greater than 90, that's either normal or CKD1, which is a very small decrement in kidney function. If the kidney function is between 60 to 89, that's called CKD2. When it's less than 15, that's called CKD5. We have these stages because even though they're artificial, we could just follow a continuum of decrement of kidney function. It gives a name to the stage that a person is at as far as the decline in their kidney function due to a whole range of different diseases. It doesn't matter what the disease is that causes the decrease. We just call that a different CKD stage. Now, there's a great backup in reserve. You don't need to replace the kidney function with a transplant or dialysis until the kidney function gets down to under 15 or so. Until then, you remain not totally healthy, but there isn't a sufficient decrease in one's health to require dialysis or a transplant. It's only when the kidney function gets down to around 15 that you start having to think of something to replace the kidney function. Now, this is total function. It's not one kidney. It's both kidneys, such that your total function is under 15. That's when you have to start thinking of what we call renal replacement therapy, which refers to either dialysis or a transplant. Now, an interesting question arises is, can you get stabilized at a certain CKD stage? So for instance, if you're CKD 2, will you stay there the rest of your life, or 3? And what we find is certain people do stabilize out. So if they get a disease that takes their kidney function, let's say from 100 down to 30 to 59, many people will stay there and have no further problem. But there is a large group of people that just keep declining in kidney function. Even though the original insult is not there anymore, they keep progressing from 2 to 3 to 4 until finally they have to go on to some form of renal replacement therapy. The rate at which people change from one stage to another varies depending on the disease process. One of the goals of seeing a nephrologist is to go on pills to try to prevent this progression. And we'll talk about some of the things that can do that, because our goal all the time is to prevent people from needing a transplant or dialysis if possible. Now, what does the kidney do? Well, the first part of addressing that is to understand what the kidney looks like under the microscope. And the kidney has these functioning units that we call nephrons. And there's about 1 million of these in each kidney. And each of these does the function of the kidney. And you can think of the function of these nephrons as twofold. The first part, which is called the glomerulus, is a filter. Like you can think of it like a filter in how you filter water or coffee filter. It prevents the components of the blood from getting into the rest of the nephron. So there's these filters, and the filters are often what are involved in many diseases of the kidney. The rest of the nephron you can think of like a pipe coming out of your bathtub, and the components of this pipe don't filter, but they do something what we call transport. They take substances and they transport them into the middle of the pipe, or they take them out of the pipe. And this changes throughout the nephron until you get what's called the final urine. So the components of what's in the pipe are constantly changing, and what comes out at the end we simplistically call urine, but it's actually a very complicated chemical solution. And we can have diseases of the filter, or we can have diseases of this long pipe, or we can have diseases of both. And the nephrologist is able to distinguish what diseases affect which components of the nephron. As I say, you have about 1 million of these in each kidney at birth. The number actually declines with age. And that's in part why I showed you on that second slide, the total kidney function declines with age. As we age, especially after the age of 50, we have less and less of these nephrons. Now, the kidney is not an organ like the heart. The heart is a pump. That's what it does. The pancreas puts out insulin. That's what it does. The lungs transport oxygen into the bloodstream. The kidney actually does many, many things. We call it a kidney, but it actually has multiple functions, which I'll describe for you now. And if someone asked you, what do the kidneys do? What they do is actually they control what we call the chemistry of our blood. Our blood chemistry is constantly changing because we're eating all the time, and we're putting a whole variety of different substances into our bloodstream. And that cannot be allowed to remain perturbed, because we will get sick from the abnormal chemistry, or unfortunately we can pass away if it gets too perturbed. And it's the function of the kidneys to recognize the changes in the blood chemistry that occurred because of what we eat and drink, and then get rid of the appropriate substances to keep the blood chemistry constant. That's the overall function of the kidney. And because there's so many substances that the kidney is monitoring, the kidney has a very complex set of functions that it has to maintain to keep the blood chemistry constant. And when the kidney function gets down to about 15% of normal, that's when the kidney no longer can keep our blood chemistry constant, and that's when we need dialysis or a transplant. So what are some of the things the kidney does? Well, the kidney maintains the chemistry of potassium in our blood very, very constant, and controls the amount of potassium then that comes out in the urine. When we eat bananas, or we eat watermelon, or we eat many fruits, we have a large increase in the potassium that goes into our blood. We don't think about it when we eat watermelon or an orange or a peach, different fruits. We just enjoy the taste, but actually we're infusing into our bloodstream a ton of potassium, and that cannot be allowed to not be corrected, because the potassium concentration in our blood determines the electrical activity of our heart. And if the potassium in our blood goes too high because we ate, let's say, 10 bananas tonight, I mean, no one's going to do that, but let's say you had an urge and you went to the fridge and you took out 10 bananas and you ate them. Well, that's a ton of potassium you're putting into your bloodstream. You could really affect the electrical activity of your heart if nothing else happened. But the kidney immediately recognizes that and dumps the potassium in your urine if it's functioning normally. So this is one of the important functions of the kidney. Another important function of the kidney is to get rid of a substance called nitrogen. There's a ton of nitrogen in fish, in meat, whether the meat is a hot dog or a hamburger or a steak or chicken, it doesn't matter. There's nitrogen in all those different meats and fish, and that cannot be allowed to go unchecked. When let's say you go to a restaurant tonight and have your favorite steak, well, you're dumping nitrogen into your blood. Well, the kidney recognizes that, and it gets rid of the nitrogen in a chemical that you might have heard of. It's called urea, U-R-E-A. So the kidney measures how much nitrogen came in and creates this chemical called urea and dumps it in the urine appropriately. The kidney also controls your blood pressure. It's the major organ for controlling your blood pressure. And how does it do that? It's because the kidney controls how much salt and how much water come out of your body in the form of urine. So if you drink 2 liters of water tonight, your kidney will recognize it and get rid of 2 liters of water. If you drink 10 grams, or not drink, if you eat 10 grams of salt tonight, let's say the food had no taste and you went to the salt shaker and poured a ton of salt on the food, well, that's going to raise your blood pressure unless something happened, and it's your kidney that recognizes that you took all that salt in, and it'll dump all that salt in the urine so that your blood pressure won't go up. Now, it's important to realize that about 45% of Americans age 18 and older have high blood pressure. High blood pressure is defined as a pressure of 130 over 80. Now, why do we have 2 numbers? That confuses people. Why does blood pressure have 2 numbers? You'd think it would have 1 number. It would be 130 or it would be 80, but why do we have both? Well, the high number is the pressure that you have in your blood vessels just when the heart beat. At that heartbeat, the heart pumps blood into your blood vessels and the pressure goes up to 130. But after the beat, the pressure drops to 80. That's why we have 2 pressures. We have a pressure just when the heart took its beat, shoots that blood into our blood vessels. But right after that beat, we have another pressure. That's the pressure after the beat, and that's obviously going to be lower. So high blood pressure, doctors look at both of these numbers, the pressure during the beat and the pressure after the beat. Some people have a high pressure during the beat, or other people have a high pressure after the beat. Other people have high pressure with both. Now, high blood pressure is something that most of the time you don't feel anything. So people, number one, don't know they have it. Number two, because they don't feel anything, they ignore it. There's many people that know they have it, don't ignore it, but don't take their pills. So It's a common problem that people tend to ignore. And the reason it's not worth ignoring is that high blood pressure definitely increases your chance of getting a stroke and definitely increases your chance of getting certain kidney problems. And it also ends up remodeling the heart. When you have high blood pressure, your heart muscle gets thicker and thicker and thicker. The heart recognizes it, and actually the muscle in the heart gets thicker. We can see that on the electrocardiogram, and that affects the function of the heart. So the goal is always to keep your blood pressure low. Now, not too low where you'll faint, and that's a problem older people have who take high blood pressure pills. In fact, their blood pressure can drop too low, especially when they get up suddenly. So if you're on blood pressure pills and you're 80 or 90, or you're on a new pill, you should get up slowly, let your body get used to it, especially if you have to go to the bathroom at night. You don't want to get up suddenly and then, faint when it's dark in the room. So you have to be careful. The other issue with high blood pressure is it's always higher in the doctor's office because there's something called white coat syndrome. When the patients go to the doctor's office, they're afraid. So we always get a higher pressure, and we ignore that. A good doctor will ignore that pressure. We don't care what your blood pressure is in the doctor's office. I mean, we care, but we don't make our assessment or our decisions about treatment based on that. What we want to know is what your blood pressure is at home. So anyone who we suspect might have a problem, we tell them to get a blood pressure cuff. And there's some good cuffs out there, Omicron. There's some pretty inexpensive cuffs that are easy to use. The younger people like using Bluetooth and having it go to their cell phone and recording everything. But you don't need that. You just get a simple machine that gives an accurate measurement. And your blood pressure that you get initially shouldn't be just once a day, because blood pressure changes like the weather. Every time you measure it, you get a different number. And that's because it's actually changing. In fact, in a normal human being, the blood pressure fluctuates throughout the day. It's highest in the morning, and then when you wake up, and then starts increasing. And then by the end of the day, it starts decreasing. And it actually is the lowest in the middle of the night. But then by the morning, it starts going up again. So there's this, what doctors call this the diurnal variation of blood pressure. So it really depends when you measure it. Sometimes people will say, oh, my blood pressure is normal. So I say to them, did you measure it in the morning? Did you measure it in the afternoon? Because you're going to get a different number. And some people have high blood pressure only part of the day. Other people have high blood pressure all the time. So it really is important to get at least 3 measurements to know where you are. I tell everybody, keep a book if you don't like using computers, or if you're used to computers, keep all the numbers on an Excel spreadsheet. And when you go to the doctor, you bring in those numbers so they can see what your numbers were. Now, the other important thing to remember is not only does the number you get vary depending on when you did it during the day, it also depends on whether you're lying, sitting, or standing. You'll get a different pressure at the same time of day if you're lying in bed doing it versus if you're sitting versus if you're standing. So you should always do it the same way. If you'd like doing your blood pressure when you're sitting, always do it when you're sitting. If you like doing it lying down, always do it lying down. And tell the doctor how you measured it. Don't just show them that you measured it 3 times a day. Say, I did it sitting. That helps them. Now, let's say you got a month's worth of blood pressures. Let's say you did it every other day or every 3 days. The doctor got a good idea of what your pressures are doing. And they notice that your blood pressure is high in the evening only. In the morning and the afternoon, you have normal blood pressure. Well, the doctor will likely prescribe a pill in the morning for you, because that pill will work most of the day until the evening, but then in the middle of the night, it'll stop working when you don't need it. If the doctor prescribes that pill at night, it's not going to be working the following night. So it would make no sense. Let's say your blood pressure is high, usually around 8 or 9 in the evening. It makes no sense for you to take a pill at 8 or 9 in the evening, because that pill is going to wear out by the morning. It's best to take it in late morning or at lunchtime. Now, you have to take it before 8 in the evening because it takes time for the pill to start working. But if you take it too early, it's going to stop working by 8 or 9 in the evening. So all I'm saying is, knowing when you have the high blood pressure, if you're going to a good doctor, will tell that doctor when to give you the pill. Not just what the pill should be, but when you should take it. So that's a very important point. And having high blood pressure is something so easy to treat. We have so many pills for it now. And it helps you in so many ways prevent future problems with strokes and other things. It's amazing how many people ignore it. But it's really so simple to measure. It's not worth ignoring. It's something very easy. You can do just like you go on a scale to see if you're gaining weight. That everybody does. But blood pressure should be thought of in the same way. You keep your weight within a certain range, keep your blood pressure in a certain range too. You'll add years to your life. Now, what else does the kidney do? Well, the kidney prevents you from getting anemic. Most people don't realize that. The kidney makes this hormone called erythropoietin, and that hormone then goes to the bones because it's the bones that make your blood. So the red blood cells, our blood is red because of red blood cells, and they're all made in the bone marrow. That's what bone marrow is. When you eat a chicken bone and you suck out the bone marrow, you're sucking out the cells that make blood. That's what bone marrow is. So all the long bones in our body have all the machinery to make all the components of our blood, the red cells, the white cells, the platelets. But the kidney is telling the bone how much red blood cells to make. And when it's not making enough, then our blood count drops and we get what's called anemia. That's what anemia is. It means we don't have enough red cells. So people with severe kidney disease get anemic. And we give them a hormone called erythropoietin artificially. And that's how Amgen, the company Amgen, you might have heard of, made its billions and billions of dollars. It cloned erythropoietin years and years ago and enabled doctors to prevent anemia for the first time in human history. Before that, we had to give blood, which has its own problems. Now for years and years now, we can give this hormone, and it doesn't matter that your kidney's not doing it. We're giving the same thing artificially, and now your bone marrow makes your blood nicely, and you don't get anemic. What else does the kidney do? The kidney controls how healthy your bones are. You know how people get, as they age, they get osteoporosis, or their bones aren't as calcified. Women are especially, wary of this, and a lot of them are taking Tums to keep their bones healthy. Well, the kidney is responsible for maintaining the calcium in your skeleton. And it does so by creating a hormone called 125 vitamin D. Now, you might have heard of vitamin D. Many people are taking it, but the vitamin D you take from a pill from the pharmacy is not 125 vitamin D. That's 25 vitamin D. And 25 vitamin D that you take in the pill is not the active form. The active form of vitamin D is called 125 vitamin D, and that you don't buy in the pharmacy. So the pill that you take, the vitamin D you take from the pharmacy, gets into your blood and is converted in the kidney to 125 vitamin D. And that is the form of vitamin D that keeps your bones healthy. But if you don't have a normal kidney, then you can't make the 125 vitamin D. And that's when you start getting bone problems. So the kidney is essential for keeping your skeleton and your bones healthy. Now, when you have kidney problems, you can predict from the number of the things I've said what you're going to have. First, you can't get rid of salt and water normally, so you start getting fluid overload, and the fluid always occurs in your feet first because of gravity. So whenever you have too much fluid in your body, you'll always see it in your feet first, and your shoes won't fit. And then you lie down and wake up in the morning and you're fine again because the fluid went back into your body when you were lying down. But when you start walking around in the morning again, all the fluid collects in the feet. So if you see that in someone, it might be a problem with their kidneys being able to get rid of salt and water. The second thing people feel with kidney disease is not as predictable, but they start losing their appetite and they feel nauseous. And the doctor usually thinks there's something wrong with your stomach, or you have a little flu virus or something, and they don't think that it could be the kidney. Because what's the kidney got to do with lack of? Well, it turns out when your kidneys are severely impaired, you don't feel like eating and you do feel nauseous. You get high blood pressure, again, because you can't get rid of the salt and water. And you get what we call electrolyte disorders. You may have heard of the word electrolyte in the context of Gatorade, or people that take drinks with electrolytes when they're running. Electrolytes just mean these substances. Now, these are chemistry symbols, but Na stands for sodium, K is potassium, Ca is calcium, Mg is magnesium, P is phosphorus, HCO3 is bicarbonate. The kidney controls all these substances, because every time you eat, you're taking in all these things. You don't think about it, but you're taking in sodium, potassium, calcium, magnesium, and the kidney has to recognize that and get rid of it. When the kidney's not working, all these things build up in your blood and you get abnormal levels in your blood, and that can lead to problems. Anemia I mentioned because the kidney makes erythropoietin. A number of patients with kidney disease are depressed, and it's not exactly clear why. Kidney disease itself can lead to some of the symptoms that are similar to depression, but a good doctor will be able to distinguish whether it's true depression or symptoms that simulate depression. It could be either. It could be real depression or symptoms like depression, but you're not really depressed. And there are ways, questionnaires that you fill out that the doctor can look at, and it tells the doctor whether you're truly depressed or whether it just looks like depression. People with kidney disease have problems sleeping, and some of them sleep during the day and stay awake at night, but the sleep is irregular. And a big complaint to people with severe kidney disease is the food tastes very bland. And so, we recommend to put a lot of spices on the food. That helps a little bit, but it's still a major problem with people with kidney disease. They just, not only do they have a lack of appetite, but the food just doesn't taste like anything to them. So how do we test for kidney diseases? There's a blood test called creatinine. And this test isn't a special test. It's not an exotic test. In fact, probably every time you have your blood measured, this is one of the many tests that comes back. And many of you that look at your lab tests online or have an electronic medical record, check out what your creatinine is, because it's a very easy way of assessing whether you have a kidney problem or not. And the normal level is around 1. If your creatinine goes from 1 to 2, you've actually lost half your kidney function. It seems like a small change, but that's how it works. And if it goes from 2 to 4, you've lost another half. So that if it goes from 1 to 4, you have a quarter of your kidney function left. Another test we do for kidney disease is not a blood test like the creatinine, but we look at the urine. And the doctors initially, just to do an initial screen, stick in with all these different squares on it. Each square represents a different substance. One of these squares represents protein in the urine. So based on the color of that square, the doctor can say you have protein in the urine or not. In normal people, there's no protein in the urine. The kidney doesn't let protein come out through the filter. It blocks protein. But in people with kidney disease, too much protein comes out in the urine, and that can lead to other problems. The bubbles here are actually from too much protein. In fact, when we see a lot of bubbles like this in the urine, we suspect there could be protein there. Most of the time it's just air because someone urinated from, high up. But if we see this and there wasn't another reason, we start thinking of too much protein. The other thing we look for in the urine is blood. So these are 4 test tubes. This one obviously on the left has a lot of blood, but the one on the right also could have blood, even though it doesn't look like it. And we check the urine under the microscope and look for blood under the microscope. So people can either have severe blood in the urine or blood in the urine that's not obvious to the naked eye. Normally, the filters that I talked about prevent blood from coming into the urine, but as they're damaged, they let the blood through and it ends up coming into the urine. The other thing that can happen in the urine is an infection, especially women who are in their 20s and 30s who are sexually active. Very common to get urinary tract infections. Clinically, it presents with burning when they urinate, or they urinate very often. That's the typical symptoms you get when you have a urinary tract infection. If we suspect a urinary tract infection, we look under the microscope, and these are all the bacteria you see here. You should never see this in normal urine under the microscope. It should be clear. We also take the urine and we place it on this red dish here. This is called an agar plate. Agar is just a jelly-like substances, but it's filled with food that the bacteria love. So if there's bacteria in the urine, we'll start getting these little, what are called colonies growing. See all these are bigger colonies, these are smaller colonies. You should never see this. This plate should look like this, just red agar with nothing on it. But if there's bacteria there, they will start to grow. This takes a couple of days, so the doctor doesn't know initially what's growing there. And the other thing that they do with these plates is they put little antibiotic discs on it, discs that are impregnated with different antibiotics, like penicillin or different types of antibiotics that are available to the patient. And if the antibiotic kills the bacteria, this will disappear over the days. It'll become clear. So the doctor can tell from the antibiotic discs what the bacteria is sensitive to, and they will prescribe that antibiotic. Now, typically, you don't want to wait 48 hours for this to come back. So the doctor will prescribe an antibiotic initially, with guessing what might work, and then modify it after a couple of days if it was the wrong choice. Typically, you're on the antibiotic for 7 to 10 days, and this will all clear up. Now, what are the diseases that affect the kidney? The big elephant in the room is diabetes. Diabetes is the most common kidney disease on the planet. It causes about 50% of all the kidney disease on the earth. Right now on the earth, there's about 800 million people with kidney disease, so about 1 in 8 of the human population. They're not all on dialysis, clearly, but they have some form of kidney disease. And in the US, there's about 40 million people with some form of kidney disease. Again, half of those are diabetic. So if we can get rid of diabetes, we would rid the planet of half the kidney disease. Now, how does diabetes affect the kidney? Everyone knows it's a sugar problem, but what's that got to do with the kidney? Well, there's a lot of abnormal metabolism and chemistry that occurs in the context of diabetes, and it's these abnormalities that affect the kidney. So what are the two major problems? The first is the blood vessels. This is a normal blood vessel. The inner wall is very nice and smooth, but this is the wall of a blood vessel of a diabetic. You can see there's yellow fat material here. The blood is clotting. The diameter of the inside is getting narrower and narrower, and you can see that that's just going to decrease the flow to the kidney. There's less blood coming through the kidney because the blood vessels coming into the kidney are getting slowly diseased. In fact, this can actually close entirely. There'll be no flow coming in. The second target of diabetes is the filter. This is a section through one of the filters that I was talking about before. This is a normal one. Look at the diabetic one. It's filled with this purple material. And eventually this could close off the entire filter. It's like having your bathtub drain filled with garbage. It's not going to drain the water. Well, if this is happening to the millions of filters we have in each kidney, you can see, that after a while, your kidney is not going to function very nicely. So it's the blood vessels and the filters that the diabetes is destroying over time. Now, there's two types of diabetes, type 1 and type 2. Type 1 diabetes is where you don't make insulin. The pancreas, for a number of reasons, stops making insulin. Type 2 diabetes is where the insulin production by the pancreas is normal, but it doesn't work on the cells normally. And that usually occurs in obesity. As your weight goes up, insulin doesn't work as well, and you can get what's called type 2 diabetes. The type 2 diabetes in general is reversible. If you lose your weight, you get down to the weight you were in your 20s and 30s, your diabetes will go away. If you don't make it go away, your blood vessels are going to potentially get destroyed and you're going to ruin the filters in your kidney. So that's a reversible type of diabetes, but it's a huge problem in America because there's a huge prevalence of obesity. People just let their weight go up and they increase their chance of getting diabetes and shortening the span of their lifespan. I tell all my patients, take a picture of how you looked when you were 25, hang that on your ceiling in your bedroom and look at it. That's the weight you want to have. And people laugh at that, but some patients say to me, Dr. Kurtz, I weighed much more when I was 25. I don't want to do that. But all joking aside, you got to get down to your ideal weight. Not only is getting to your weight important for diabetes, it's essential for keeping the bones in your spine normal so that you don't, get a bent back when you're 85 and 90, like most people do. You want to keep your back strong. It's easier on your leg muscles so that your leg muscles can carry your weight around. You want to watch your posture. You want to maintain a healthy lifestyle. Keeping your blood pressure, as I mentioned before, and your weight within a normal range is really, really, really important. You're going to prevent a lot of diseases in your 70s, 80s, and 90s, and you're going to keep yourself out of the hospital to the extent that you can. Now, obviously, you know, we're all human and things occur that we have no control over. But a number of these things are totally within our power. We just have to have the willpower to look after our bodies like we look after our cars. I mean, everybody takes their car in, everybody checks their tires, everybody checks the oil, the transmission. We have to have the same approach to our bodies. Our bodies are a machine. We have to look after them. We have to really, really care for our body. And a lot of it's within our ability and willpower. We just can't be lazy about it. So diabetes, for most patients, is type 2. And because of that, most of the kidney disease we see is totally reversible. It's very unfortunate. It's created by people. They don't have to have it if they just watch their weight. So diabetes, that's a big one. Another disease, very common in Southeast Asia, is called IGA nephropathy. It typically presents with blood in the urine. We'll have a 25-year-old girl. She'll come to the clinic and say, "Doctor, I was fine. I got a little bit of a cold, and then the next day I was peeing bright red urine. What's going on?" Well, the first thing we ask anyone who tells us they have red urine is, did you have beets the night before? Because eating beets the night before is the most common cause of red urine. We get that all the time. People eat beets, the next morning the urine's all red, they freak out. They think there's blood in the urine. We just say, wait till the evening. It'll clear up in the evening. It's just the beets you ate. But obviously, if it doesn't clear up, it obviously can be blood. There are other things that cause the urine to be red, but in general, it's due to blood. We look at the kidney again. Here's a filter. And this filter, you can see also, for those that are used to looking at, this is abnormal. There's just way too many cells here. The doctor calls that inflammation. This filter is really inflamed, and it's not going to function normally. The green is just a test we do for this particular disease. You should never see any of this green. It should be clear. So this is called IgA nephropathy. It's very, very common in Southeast Asia and among Asians in North America too. It's a common kidney disease, not as common as diabetes. And diabetes and this can lead to such severe kidney disease that you need to go on dialysis or get a transplant. Some people, as I say, it levels out at an earlier stage, but many just progress and progress until they have less than 15% of their kidney function and they have to get something done. Another thing that we see are kidney stones. 15 million Americans have kidney stones. These are some of the stones. They're real stones, and they come out in the urine. And the thing to know about this is the pain starts in the upper back where the kidney is, and it goes around to the front and then goes into your groin. It's the worst pain a human being could feel, even worse, they say, than giving birth to a baby. People are screaming and crying on the floor with this. And what we do is we give them morphine. The first thing we do, we don't care about the stone. We don't care about anything. We just want to stop the pain. So we give them morphine, and right away they feel much, much better. Then we'll work out what's going on. There's many different diseases that lead to these. The stone can come out in the urine. It may not come out in the urine. It may be stuck in the kidney. There's many things and approaches for this. One approach is to pulverize the stone with ultrasound. So you go into this vat of water and ultrasound waves are targeted at the stone very, very accurately and just blast it apart. If that isn't the approach or doesn't work, the doctor can go in with different instruments and blast the stone into tiny dust particles, and then they all just come out. Now, if the stone is bigger than 2 or 3 millimeters, it will not come out, and that's what causes the pain. If the stone is smaller than 2 or 3 millimeters, you don't get the pain. It just comes out, and if you're lucky, you'll catch it. If you do have a kidney stone, try to catch it, because all these stones have different chemistry, and their different chemistry tells the doctor how to treat it. This is another disease. It's a genetic disease. It's passed down from parent to child to grandchild, and it's called polycystic kidney disease. And this is what the kidneys look like. They look horrible. They look like a bunch of grapes. And this occurs slowly over time. You can be in your 20s and 30s with this disease, you have normal kidneys. But as you age in your 30s and 40s, the kidneys start getting more of these blebs. And this is causing about 5 to 10% of why people are on dialysis. It's not an uncommon, it's probably the most common genetic disease of the kidney causing people to go on dialysis. This is another disease you might have heard called lupus, tends to occur in young girls or young women in their early 20s. Again, it's an inflammation problem of the filter. Here's a normal filter on the bottom. Here's a filter that's all inflamed. Look at all these cells in the filter. There's no way the kidney is going to be able to filter normally. And again, it doesn't just affect one, it's affecting the millions of filters that we have. All of them are being affected. This disease is not just inflammation of the kidney. You can get inflammation of the brain, the liver, the heart. See the red rash she has? That's because the skin under her cheeks is inflamed. This is not due to the sun. This is actually inflammation under her cheeks. We call this a malar rash. We see this, we start thinking of lupus. You can get all sorts of other abnormalities too, like unfortunately, they can have their hair fall out. It's not a pleasant disease to get, but the kidney is one of the affected organs. Rarely you can get cancer of the kidney. It's not a common cancer. This is a CAT scan of the abdomen. This is what a normal kidney looks like here, this horseshoe here. This is a kidney with a cancer in it. You can, even if you're not a doctor or radiologist, you can see the difference between the normal and the abnormal. And this is just a cartoon of a cancer within a kidney. Now, if we have cancer of the kidney, we have many approaches. We can go in with radio waves and destroy the tumor. We can take out just part of the kidney. We try to do that because we don't, if possible, want to take out the whole kidney, because then the patient will have less kidney function, 50% to start with. As I say, the other kidney gets bigger over time, but we try to spare the normal tissue. Not a common cancer. Now, as far as dialysis statistics, there's about 650,000 people in the US on dialysis. Every year, about 100,000 new people are going on dialysis, and about 100,000 are passing away. So we have a pretty constant number of about 600, 650. Now, we're getting better at decreasing this and decreasing this, but this number is fairly constant and is sort of a number you can remember. You can also remember there's about 100,000 people in the US waiting for a kidney transplant. There's a long transplant waiting list. In Los Angeles, if you go on the waiting list for a transplant, a deceased organ, I'm talking about a kidney from a deceased person, you'll wait 10 to 12 years. So we recommend now a living transplant, a transplant from a living person. We'll talk about that in a minute. So we have 3 ways to replace the kidney if the function has gone down to less than 15%. One is dialysis. This was invented in 1942 in Nazi-occupied Holland. There was a doctor there who worked in a small little hospital trying to evade the Nazis and invented this technique called hemodialysis. And this is essentially what we're doing years and years later. Nothing much has changed. Typical patient comes in 3 times a week and receives 3.5 hours of treatment. The blood comes out of the arm, typically. The needles go into something called a shunt or a fistula, where the vein in the arm has been hooked up to the artery. We need high blood flows for this. The blood is flowing quite quickly into the machine. We don't want to go into an artery because the pressures are really high. We can't go into a normal vein because the pressures are too low. So we hook up the artery to the vein, the surgeon does, and then after about 6 or 7 weeks, that's what the blood comes out of, goes into the machine, goes through this dialyzer here, and then back into the patient. It takes about 3.5 hours. Some people who don't want to come to the dialysis unit do it at home. They get a machine, and they have to, that technician has to be paid, and they do it either in their office or at home if it's more convenient. That's about 7-8% of people in the United States now. Most people are on what's called in-center hemodialysis, where they go 3 times a week. You get Sometimes to pick the shift, they do early morning, late in the evening. Oftentimes, the dialysis units don't have the openings that you might like. You either go Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. During the procedure, you don't feel anything. Oftentimes, people are bored. They either sleep, read their iPad, watch television. The doctor weighs you when you come in, and they weigh you when you leave. Now, why do they weigh you? Well, imagine if you don't make any urine. So let's say this man in the picture makes no urine. If he drank a liter of Coca-Cola the night before, he's going to gain a kilo of weight. Nothing, it's not going to come out. If he drank 2 liters of Coca-Cola, he's going to gain 2 kilos. So by weighing you, the doctor knows how much you drank, and they know how much fluid to remove with the machine. Because the machine controls how much fluid and also many other chemicals are removed. Now, the other form of dialysis is not with needles in your arm and does not involve blood and is called peritoneal dialysis. About 15 to 20% of Americans are on this. This you do at home. You don't go to a dialysis unit. This you do typically at night. And what the machine does is it puts fluid through this little catheter here that the surgeon has placed into what's called your peritoneal cavity. The peritoneal cavity is a very small sac under your skin here that normally is empty. But if you put fluid into it, it blows up like a balloon. So what this technique does is the machine instills fluid into the peritoneal cavity. It sits in the cavity for 2 hours. All the waste material that built up in your blood goes into this fluid, and then the fluid is drained, and then a new bag is put in. And that's what this machine does. And it's happening while you're sleeping. You hook up all these bags before you go to sleep. While you're sleeping, this is all occurring, occurs over 9 or 10 hours at night. In the morning, you unhook yourself here, and you go about your daily business. This is by far a better procedure if you can do it, because you're doing it daily. It's much more gentle. It doesn't involve the severe changes in blood that you're doing with the other machine. The other machine you're doing 3 times a week. This machine you're doing for 8-9 hours every night. So it's much better for your physiology and for your medical well-being if you can do this. You have to be careful when you hook up and when you disconnect. So you have to wear a mask and gloves. Well, everybody's used to wearing a mask now. Before 2 years ago, that was a big deal. So you wear a mask, you wear gloves, and you do it sterilely, so because you don't want to get an infection here. The other, obviously, the best approach, if possible, is a kidney transplant. Kidney transplant, people ask, what happens to your other kidneys? Well, you actually end up with a 3rd kidney. They don't get rid of these kidneys, even though they're functioning less than 15% of normal. They still may be making the hormone erythropoietin, so you don't get anemic. They still be making some vitamin D, the 125 vitamin D, so your bones are healthy. So it wouldn't make sense to remove them if they're doing something. You might as well take advantage of it. The transplanted kidney goes here, typically, more to the front. In the future, there's 2 big areas of change in the future. One is xenotransplants, which are kidneys from a pig. Right now, as I mentioned, there's about 100,000 people waiting for a kidney transplant. So if we had another source of kidneys, that would be able to alleviate some of this backlog. So a number of doctors are working on pig kidney transplants, and there are many technical issues. One is the rejection, because it's another species. That's being worked on. And the second major issue with the pig kidneys is pigs have in their DNA viruses, viral DNA in their normal DNA. And there's a great fear that if you put this kidney into a human, you're going to get all the pig viruses growing in the blood and killing the patient. So there's a lot of work going on getting rid of the viruses that are normally in pig DNA, to rid their kidney of any foreign viruses, viral DNA. And once that's done, then all that will be needed will be to work on the biology of making these organs not reject. And my gut feeling is it's going to take another 5-10 years. Another big area, my lab, my group is working on this very heavily, is to create a totally artificial kidney made by chemical engineering and electrical engineering principles that is not cell or biology based. It's synthetic materials to try to replicate the major functions of the kidney so that we can in the future have either something portable on the desk that people can use, or ultimately something they can wear on their waist. The ultimate goal is to make an implantable organ. So I'm working quite heavily on this now. And I think I'll stop there. These are 2 happy kidneys, so keep your kidneys happy. Make sure you know what your creatinine is. Tell all your friends and relatives to get their creatinine measured so that they know exactly what's going on with their kidney function. It's something that's very easy to do, very commonly done. And as I say, whenever you go to the doctor and have your blood tested, they're measuring your creatinine. There's something else you might see, call it eGFR. That's just another number that is calculated based on the creatinine, but the creatinine is the key number to follow. And if you can keep your kidney function and your kidneys happy, you will have a major headache that you don't have to think about when you reach your 70s, 80s, and 90s. In fact, if you look at our dialysis units, the average age now is in the 70s. It used to be, every decade it's going up by another decade because we're keeping people healthier and healthier as time goes on. There's no age limit to how long you can be dialyzed. We had a woman in our dialysis unit who was like 104, and she was bringing brownies in for all the patients every time she got dialyzed. So there's no limit. It's inconvenient to go on dialysis, but it's not the end of the world. And a lot of it is how you approach it. Many people think it's the end of their happy life, but it's really not. It's an inconvenience, but it's not like getting severe cancer or other things that can, deeply affect your longevity. You can have a long and happy life on dialysis, but obviously it's better to prevent getting any kidney abnormalities in the first place. So with that, I think I'll stop, and I'd be glad to take any questions anyone might have. If anything I said wasn't clear or you have some questions. Also, you have Leslie, my assistant's email. If you would rather not ask any questions in public, please email her, and I'd be glad to get back to you confidentially and help you with in any way I can with any problems you or your families might be having. So does anyone have any questions at all? Okay, well, I hope you got something out of that lecture, and till next time, have a great evening.